So, as I said, you're all very welcome, and I'm very pleased today to be joined by some expert speakers. Just by way of background, Maternity Action has written 3 guides on charging, one of them aimed at the administrators and the people who might want to read more broadly about the guidance and what the charging regulations mean and sort of general good practice advice on that. And that was published last year. Earlier this year, we launched a guide that had been written together with the Royal College of Obstetricians and Gynecologists. I'm happy to say today we're joined by midwives, and so I don't have to stumble over those words repeatedly throughout the session. So the final guide, is aimed at midwives. The focus is on women such as those we help at Maternity Action and such as those who are joining us today. Women who live here. They're not tourists in the UK. They live here and have either been charged when they should have been exempt, and we'll talk a bit more about that in a moment, or who don't have the means to pay for their care, even if the charging was technically correct. They don't have the means to pay for their care due to their income or lack of it. So, as I said, this piece of guidance is the last of 3, and we've produced this in conjunction with the Royal College of Midwives. It was actually mainly drafted by my colleague Catherine Pellegrino, who ran this project before she left Maternity Action in the summer. So I'm joined today by Rachel, who's from the Royal College of Midwives, Esther and Sheila, who are women whose expertise is from their own experience of being charged, and Dr. Hannah Raymond-Jones, who's a midwife and academic. Each of the speakers will talk a little bit about the guide and the reasons for being involved in this project or looking at it, and the impact upon women who are charged for maternity care. So I will say more as I introduce each speaker. So, without further ado, I shall introduce our first speaker, who is Rachel Drain, who is a midwife and whose role at the Royal College of Midwives is the Quality and Standards Advisor. So over to you, Rachel. Thank you very much for joining us today.
Thanks, Judith. It's great to be here with everybody and representing the Royal College of Midwives. We've been really keen to be involved in this project and have co-authored it alongside Maternity Action. It's a great resource, and really I just want to talk a little bit about the role of the midwife in terms of our interactions with these women, what the responsibilities of midwives are. So as we know, as midwives, we are with women, we support them, we advocate for them, and we empower them. And we do that through building a relationship of trust with women and with families. Midwives can be critical to tackling inequalities. And we know that migrant and asylum-seeking women who are affected by NHS charging are disproportionately likely to be from Black and marginalised ethnic groups. And the Embrace data tells us that the health outcomes for these women and their babies are often worse than those of white British women. We know that pregnant migrant women are a uniquely vulnerable group, given that many will have had a long journey to arrive here in a place of safety. And midwives are perfectly positioned to lead the efforts to tackle the health inequalities that they face. As I've said, midwives' role is to advocate for women, and in terms of for this guidance, this can require engagement with the overseas visitors team and acting as a conduit between the woman and the overseas management team. It's particularly important on occasions that overseas teams are trying to reach women to establish if she might be exempt from NHS charging. And this is really important. These women who fall within the category of exemption, women who have endured torture, female genital mutilation, domestic abuse, or sexual violence. And we know that by developing a relationship of trust, midwives can make additional sensitive inquiry where appropriate, at the same time as being really firm and clear with overseas teams that it's never appropriate or acceptable for them to attend clinical appointments to discuss charging with women. that is solely reserved for delivering clinical care, for building that relationship, delivering clinical care, and safeguarding those women from feeling ambushed, really, I suppose is the right word, that come into their antenatal appointments, they purely are there to come and see a midwife. We know that midwives have a role in signposting women for more specialised support and advice where appropriate and necessary. So, for example, women who are notified that they're subject to charging might be deterred from attending, and this can result in higher rates of morbidity and mortality. We know that overseas teams can make errors in their judgment about women who are subject to charging. So it's important that women have access to independent and specialist advice. Midwives are really well placed to do that. So there's, we're going to talk more about the guide, but it's really useful resource, and that's just a quick overview of how midwives can support these women. Thanks, Judith.
Thank you very much. I think it's true to say that whilst Royal College of Midwives and Maternity Action and other organisations are very troubled by the fact that because of the impact on women and the likelihood of it deterring women from seeking care from a midwife and other clinicians, we're very concerned about the charging regime, but we all have to work within it at the moment. And so this guide is aimed at those who might be able to help, as Rachel says, without casting any judgment as to whether or not the charging regime should exist. So the guidance is around working within the current legal framework, which does require some women to be issued with charges for their maternity care. I'm now going to introduce two women who've had experience of being charged for maternity care and who are part of a group of women who have been affected by charging due to their residency status in the UK. I'm going to invite Esther and then Sheila to talk about the issue from the perspective of women such as them who have been charged for maternity care. We're so grateful to have this insight. You really are experts by your own experience and those of women with whom you talk and meet. So I'm going to ask, first of all, Esther to give us your perspective and to give us the messages that you want people to hear, Esther. Thank you very much.
Good afternoon, everyone. Can you hear me, please?
We can, yeah.
Okay. My name is Esther, and I live in London, and I'm a mother to 4 beautiful children. So I've had my own fair share of NHS charging. So I've seen the good, the bad, and the ugly side of NHS charging. But the message I really want to pass now is because during my own process, I had a C-section, so I was still in the hospital. And for me, I was a bit informed because my immigration status was kind of precarious in the sense that I was changing from one status to the another. So while I was on the asylum, I had support and Section 95 support, which means I'm able to access NHS charges, the welfare benefits, even though I'm not a British yet, but that support gave me the right to be able to access all this. So I just had a C-section and I was in the recovery room. And the next thing I knew was this overseas whatever came to my bed and was like, oh, your name flagged that you are supposed to pay. I said, no, I'm not supposed to pay. And first of all, I don't appreciate you coming to my room like this, that I just had a C-section. I don't know who allowed you. She said, okay, but I'm an asylum. I said, yes, I am an asylum seeker, but I am on support 95. Did you check your notes before coming to me? She said, my name flag. I said, you said that already, that my name flag, but I'm entitled to this of it. And at the same time, so I pressed the bell. So one of the nurses came in. I said, I don't want to be disturbed. I just had a CS. I'm going to baby blues. My emotions are high. You cannot come and tell me about payment now. I'm still recovering. So she apologized and then she left. When my partner came in, I said, this, and this is what happened. So I was like, okay, thank God I am informed and I'm educated, so I know my rights. What if it were to be somebody who doesn't know anything about this? Can you imagine how this person will feel? So I think after I got discharged, and thank God I had a very good midwife. My midwives were the roasting team midwife in King's College. So I told them about this. They were like, no, Esther, you're not supposed to pay. You understand? The fact that I was even a survivor of FGM, so that brought a flashback to me and every other thing. So I was going through a lot of emotions and everything. You understand? So when my midwife came home to check on me, I told her that this thing is still bothering me, that I don't know why they will be asking me to pay when I'm not supposed to be. I don't want something that will affect me in future, you know. So I think 2 weeks later, I got a letter of apology from them saying they were sorry that the person who did my paperwork didn't go through the diligent route to know that, yes, I am on support 95, so I'm entitled to you. You know, I was like, I felt relieved, but at the same time, I wasn't happy because in the first place, you're not supposed to come and tell somebody who just had a baby. You don't even know the condition the person was. You don't know, this is somebody that you don't know if I'm a victim of modern day slavery. You don't know if I'm a victim of DV. I mean, everything was just running back to my mind. I was like, what if you had told somebody else the story and the person from there just went off like that, and the person, they're not able to revive the person back there? So for me, I think the recommendation for me, I don't think anybody from the overseas team should be allowed into the maternity ward. If there is anything, like you said, our midwives are meant to be somebody who can trust. I mean, gotten that trust with them. It's a journey of 9 months. It's not somebody I'm just meeting yesterday. So from my first day of going to antenatal, I have told them, they've read my file. Even the first day that the midwife wanted to test me, the first thing she said was, are you a victim of FGM? I told her, you know. So they have all this in place. So they shouldn't allow people who know nothing about what somebody is going through, or you just feel because your name flagged on the system, then you just come and then go and talk to the person that just had a baby. You don't know the condition the person is. You don't know if the person can talk. You don't know the trauma the person is going through. So I don't think that is fair on that. I'll stop for a while and I'll give Julia the time to talk. Thank you so much.
That's amazing, Esther. I mean, that's just really so powerfully spoken about what the guide is meant to do. We just need a recording of you, really, to make sure that the midwives understand, and the overseas teams, as you say. I'll pass over to Gila now, and then once everybody has spoken, we might have some questions and return to you. But for now, thank you very much for your input. Gila, over to you.
Good afternoon, everyone. I hope everyone is okay. You can hear me properly. I'm Gila. I'm mom of 3 beautiful girls. It's quite tough to pass my experience, but now I'm more than happy to pass the good and bad experience have been passed. First of all, I came from the UK since 2024. 2014, and since that time I came over to one of my daughters, and then I had the 2 of them here in this country, and I have good and bad experience as like Esther. The good experience is a new environment, a new hospital, and the way they attend is really different as I knew, and but I noticed one thing who made me a little bit afraid when I had my second daughter. I was being passing a bad situation in my relationship, but because I was a little bit afraid to speak myself, and I just was waiting for if it's somebody gonna come to me, and then I can trust that person. And I didn't see no one who I can trust to explain my situation. And when I had my third one, I was in the hospital with I called the ambulance, and then I say I have a stomach pain. And the paramedic just said to me, how bad is the pain? I said, it's really bad, and I'm pregnant. And he said, okay, give us a minute, we're gonna come, because I was living very close to the St. Thomas Hospital in that time. And they, like in half an hour, the paramedic was in my house, and they look after me, and they said something is going on. Is it strange? And there was a look at me, and I was just surprised, because the only thing I knew, it was like my stomach was pain, but they said no, something going off. And I had that going off. What's that mean, going off? I was asking myself, what's that mean, going off? As a pregnant woman, I was saying, maybe the baby died, maybe I'm gonna die. I was asking myself a lot of questions. And when we went to the hospital, I saw a lot of doctors, midwives, all of these people around me, and asked me about, how many things I can see, and what happened. And I was explain everything I was seeing. And then they say to me, that is not normal, because I just had, they said, eclampsia, something like that. And they said the immune system is not working, it's not working. And then when I wake up, I was seeing the baby next to me. And my ex-husband said they asked him, this is the message my sister passed me, they asked him to sign the paper to in case who they're gonna save, me or the baby. But during my pregnancy, I was past a lot of personal reason, like domestic abuse, I think, like that. And I went into hospital to GP so many time, and I don't feel, support in there, because if the pregnant woman come to you, that means something's going on. They're just not gonna go to hospital so many times with no reason. But because my ex-husband bringing me here, I was afraid, because the words he said to me, I was afraid if I can trust in that person. I think more people are passing this situation, and they don't have the support. They don't trust in the midwife, because they don't know if the midwife is gonna help them, or they're gonna take the kids, as my ex-husband said to me. If you say anything for the people, they're gonna take your kids. And then I was very afraid. Maybe someone is passing this situation now, and then they're afraid to explain themselves. They're afraid to say, no, I have that pain. I need your support, but because of that and this is the I can't explain myself. And other things I've been past is sorry. Um, I feel like the midwife, you need to be more compassion, have a more, more love in the heart. I know it's quite hard. It's too much people go to be attend. I know sometimes we have our back home problem, and then you bring it to our job. But when you face other people, you need to help others. No one gonna come to you because they don't want to. They're gonna come to you because they need it. And then when they come to you, I think they need to be more compassion, more care, more woman. They have more human beings, to listen, and then they try to understand what's going on. Because imagine if it's now I can say to myself, I can explain myself, I can say stop, but before I can't. Sometimes people are passing this situation, and the new people who are passing situation like myself, now I can help them. But and the same time they come to me and say, I went into the hospital, but the midwife was a little bit rushed to me. They said why I became more pregnant. Sometimes they are forcing to be pregnant. It's not like they want to, but because they don't know the right, they don't know who they can trust, and then they just feel themselves like put one feet on under than others. Um, it's quite stressful to say about the midwives now, because the area where I live in now, if I call the GP to say about any situation, they're gonna say to me, go online. Imagine that you're pregnant and then you say to your GP, I called because I feel pain on this area. I'll go online and book you appointment online. If you're not speaking English, if you have a difficult, if the pain is so constant, you go to hospital. The hospital are busy as well. I know there are lack of staff at the moment, but I think we have to open and then give another option, another opportunity for people, because there's so many people are suffering. And then and I really understand the NHS doing the best. I really understand midwife do the best, but I believe we can do more than that. I believe we can trust midwife. We can trust the people around us. I believe there are good people in the world, but if we now have that support, it's quite painful. I can say I'm here, I can talk, but 4 years ago, I was I was feel like I will be die. I'm not gonna see my kids grow, but now I can say, I can talk, I can encourage my kids to keep going, to don't give up, never give up. Everything's gonna be okay. But still have people who need our help, who need the support, who need this midwife to care and give them a hope in the future. That is my...
Sheila, thank you so much, and thank you. And I'm sorry that it was distressing for you to tell. And I hope that just by being here, you do clearly understand that it's really important that people, professionals, understand that women are in a very vulnerable position anyway, being pregnant, and your health might not be great, but that there are other things going on that mean you need your midwife support. And then there's an extra layer for women who are subject to charging, whether incorrectly administered, as Esther referred to, or even when correctly administered, there is good practice around how this should be done. I failed to do a little bit of my job because I've seen in the Q&A a question that I think is worth addressing now, and then Hannah, when we come to you, you can revert back to this sort of role of the midwife, and as Rachel reminded us, the midwife is with women, and Esther and Sheila have given us really powerful testimonies around why that is so important. Even when you are able to advocate for yourself, there are lots of women who aren't. So the charging regulations apply to people who are not ordinarily resident in this country. And that's a legal term that doesn't mean, does the person live here ordinarily? Because lots of the women we help, and lots of the women that Esther and Sheila are talking to, live here. So it's about your legal right to be here. And, you might be in a process applying for leave to stay, or you might have conditions on your leave to stay. So it's a technical term that is explained in the guidance. There are exemptions. There are some exemptions on some health provisions, such as HIV services, that are exempt from charging. And then there are exemptions that are attached to the circumstances and experiences of the people, the patients, as we might say. And they include where health treatment is required as a result of female genital mutilation, sexual violence, domestic violence. You might be in the asylum system. So there are a list of exemptions, and they're explained in the guidance. I do hope people are able to read it. It's quite short. We've deliberately kept it quite short, particularly on the advice of the Royal College of Midwives, saying, midwives are busy. They need a concise sort of explanation of the guidance, and sort of knowing when to seek help and advise women to go for further help. So hopefully the guidance itself will explain more. But yeah, I should have done that earlier. So thank you for the question. I'm now going to introduce our final speaker of the morning. He's Hannah Raymond-Jones. He's a midwife and researcher based at King's College London, and she'll talk to us about her study into NHS charging, the effects of this, particularly on the health of women and babies. But I will pass over to Hannah to explain a little bit more herself. Thanks very much, Hannah.
Thank you. Thanks, Judith. And thank you to Esther and Sheila. I'm just going to really back up what you've just been speaking about. So, as Judith said, I'm a midwife and a senior research fellow at King's College London, and I lead on the No VPF project, which is a 5-year programme of research that examines how current immigration policies affect maternal and child health. So we are specifically looking at no recourse to public funds and those who might be subject to NHS charging for their maternity care. And so this programme of research uses a mixed method. So we're kind of analysing large data sets to understand access, engagement and clinical outcomes, and then interviewing women and their families and health and social care professionals to get a better understanding of the kind of the reasons that are underpinning the findings that we get. And a lot of that comes back to a kind of a fear of NHS charging, a fear of the unknown, a fear of it, and women not knowing their own rights, and health and social care professionals, just being not very confident in how they can address these issues as well. Both Esther and Sheila are a part of our large lived experience group of women with precarious migration status. And so, I just want to, I guess, reiterate the issues that they've spoken about today and that they are extremely common across migrant communities. So women have consistently spoken to us about a range of persistent challenges during pregnancy and motherhood. Things like communication and language barriers, a lack of information about their own rights, financial and housing insecurity, food insecurity, mental health difficulties, social isolation, and then disrupted continuity of care, often due to being moved across areas and different NHS trusts. And also this, often these experiences of unsafe or disrespectful care that are often underpinned by racism and bias. And all of these things are just made worse by the fear that is associated with NHS charging. So to get a better understanding of kind of professionals context, last year we conducted some focus groups and a national survey with health and social care professionals. And I just wanted to highlight a couple of the findings that were relevant to this guidance. So our survey found that only 32% of healthcare professionals are routinely asking women about their overseas status or potential NHS charging eligibility. And this wasn't surprising to me, but I think many midwives came out and spoke about the reasons for this. And, they've told us that they worry that asking women about their immigration status could put them at a risk of charging or even deportation. And others just felt like they lacked sufficient knowledge on how to offer advice or answer questions, particularly around NHS charging, in a confident way. 80% of healthcare professionals have never received any training on immigration status or NHS charging, and nearly 90% reported that they feel that they need to improve their knowledge in this area. I think this all comes back to what Gila was talking about as well. This is more than asking someone about their immigration status. This is about developing trust and being able to ask about, the wider factors, the wider issues that are going on in women's lives so you have some kind of information there to be able to share with overseas offices that might, lead to exemptions in charging. And just to be able to advocate for those women. But as Julia was saying, we need to gain women's trust in order for them to tell us these things. So we asked professionals what they thought would help kind of fill these knowledge gaps. They had a wide range of suggestions, a lot around written guidance, training sessions and workshops, online resources, and personalised tools to help them understand what different immigration statuses mean, because it is a complex area. And help them understand what women, about their rights and the support that might be available to them. And then some midwives suggested a kind of a stepped level training, so with more in-depth education for specialist roles, such as those in safeguarding leads, and a more kind of simple foundation level for the wider workforce. And so I think this new maternity action guidance is a much needed first step in addressing these knowledge gaps, and I do hope you're able to share this widely. Going forward, we are planning to bring together these resources and guidance such as this and support their implementation within the NHS settings and university curricula. And we will obviously also continue working with policymakers so that our findings on the kind of the impact of hostile immigration policies are part of the national policy debate and hopefully reform one day. Thank you so much, and do feel free to get in touch if you'd like to know more about the project. Thank you.
Thanks very much, Hannah. We've had a couple of questions, one of which I answered live, and one was a message to our lived experience speakers, our experts, through their own experience, offering strength and solidarity, which was lovely. So thank you very much for that. I feel a bit like I'm putting people on the spot now. I'm coming to you, Rachel, in a second. It's interesting to hear those findings. I mean, worrying, I guess, to hear the findings around midwives feeling like they need more support. Can you explain a little bit more about safeguarding? Because we talk about safeguarding in the guidance, don't we? We talk about flagging safeguarding issues and talking to a safeguarding lead. And I think that's a message that the Royal College of Midwives wants to get over, isn't it? Is seek help. You can't be an expert on everything, but do seek help. So is there anything that you'd like to say on that?
Yeah, absolutely. That is a theme that is kind of nationally comes up all the time, about escalation, which is essentially what you're talking about. And absolutely, you can't be expected to be an expert in everything. So it's about knowing when is appropriate to seek help and to whom you go for that help. And I think it was interesting, the two things that Hannah said, they go hand in hand. The low number of midwives who routinely inquire on women and the high number of midwives who have never received any training. And I think that it stands to reason that they don't perhaps ask because they don't know what to do with that information when they get it. They don't know how to handle that situation, or perhaps how to deal with the answers that they might be given because they haven't received adequate training. So it's not the fault of the midwives, it's the fault of the system, again, that actually midwives are not receiving training in exactly what we've got here in this guide. These are the women who might be exempt from charging. This is what this is the process that you follow. These are your, women's rights. These are who you signpost them to. If that was delivered to midwives in a, regular and comprehensive way, that training, then midwives would feel empowered to actually say, okay, you know what, I'm going to make this part of my routine inquiry, just like I do with domestic abuse or fetal movements or anything else that we routinely ask women, at each occasion that we see them, to adopt this practice, inquiring about women's status. If they know what to do with the answers that they get, they're more likely to do it.
Thanks very much. And I think that issue that you touched on and Hannah touched on, around sort of not wanting to ask from a view that this might protect the women from something if they don't ask. And we've seen from Esther's experience that actually that's not realistic. It's not protecting women to not ask them about the status and to be able to make the proper inquiries and look into it. Because you talked, Esther, about someone saying this was flagged, and we know that there are systems that identify people either because of the visa they've applied for or because of the NHS number. That means that sometimes women, such as yourselves, don't find out about charging until after you've given birth. I know from Maternity Action's experience, that's not uncommon. Some women don't find out until much later in the process, so that there's nothing that they can do about the charging and getting proper advice not until it's too late. We would always say seek help and advice at any point that you get notification of charging, but it doesn't really protect women to sort of think it's all going to go away, because we know that that's not the case. I don't know if there's anything else that you want to say, Esther or Gila, on that from other women you've spoken to around experiences when they get bills or anything like that.
Yeah, I just wanted to say something based on the guide I read. I mean, there was this part that said if they don't pay the money, then they will be reported to the Home Office. I think for me, being an experienced son, I think if that clause is not there, people they will feel relaxed. But them saying that clause wouldn't even want them to come forward because they were like, because that's the process that if I don't do anything, they will pass my name to the Home Office, and at the end of the day, my visas will be revoked. I will get my visa, then I'll become a overstayer, then they'll be forced to remove me. Yeah, all the guidelines are there, but I wouldn't want. I would say if there's a way to take that off it, you know, like for me, I always say something about Bill of Rights. I mean, if all the midwives and people who are pregnant, if they have a Bill of Rights, they know that okay, it is my right not to be visited when I'm in the labor room. It is my right for nobody to come when I'm recovering. It is my right to be treated with respect, with dignity. It is my right to know if I'm going to be charged. It is my right to for the my midwife for me to have a trust in my midwife and for midwife to trust me so that I will feel like I'm in a safe ground and I can discuss anything with her because this is a 9 month journey and she's taking care of me and my baby. So if we have all those Bill of Rights in place, you know, maybe during the appointment, you get antenatal care, you hand them that and then you talk to them, make them know that it is okay not to be okay. You are not alone. Help is there, you know, but all you need to do is just say it out. Yeah, it's not easy for somebody to just see somebody and trust, especially we of colors, because I know what I went through, especially we of colors. When you talk to them, they believe everything spraying out of your mind, of your mouth is rehearsed. But these are not real statements. These are reality. This is what we have gone through. So if that mentality is taken, because before you say anything, you are already judged. And I'm speaking from experience now. So if I want the midwife to have empathy, they should not sympathize with us, but let them have empathy that these are human beings. These are people bringing people to the world. Make that place a safe space for them so that they will feel, oh, I have a midwife I can always run to, and she will signpost me to where I need to go. Now, if I ask you a question, you will say, but you're supposed to know this. I'm not supposed to know anything. That is why I have come here. You're supposed to tell me that, okay, I'm taking paracetamol. No, Esther, you're not to take paracetamol. Instead of paracetamol, take water. You know, so if you tell me all this, it's my right to know all these things. So if those Bill of Rights are put in place, I think it's going to help in the long run. Thank you.
That's a really interesting point, actually, Esther, isn't it? Because you talked earlier about in your personal situation feeling like you could advocate on your own behalf, but lots of women in this situation won't be able to do that. And so you're sort of saying, yes, tell us what our rights are, tell us in advance. And I think that's a really important message. And you know, for midwives, similarly, we would really encourage people to familiarize themselves at least with this guidance that RCM and ourselves are launching today. The actual guidance does talk about the proper process that should be gone through in terms of telling women that they are likely to be charged, explaining to them that they might have things that they want to say that might make them exempt, you know, for the health trusts, the health boards to actually make some investigations into that in terms of ensuring that they've got the right information, for instance, about an asylum seeker who shouldn't be charged, giving estimates of bills, letting women know that they should get a bill, you know, after the care, and that the bill might vary according to the kind of care that you get. So if you do stay in the hospital afterwards, that's going to be more. And of course, about, as the regulations currently say, the reporting of that to the Home Office. And Maternity Action, and certainly I know Doctors of the World who are on this webinar, trying to work towards a system where people are not charged when they actually live here, that they're not overseas visitors, as the guidance refers to them, but that people who live here shouldn't be charged, and particularly those who don't have the means to pay. So lots of women, and I think some of those in your study, Hannah, are women who really are either supported through, asylum support, or through local authority care, which gives them the very little money, just enough to subsist on. There's no means to pay the big bills that are given to women. The regulations say that the charges have to be, unless you're exempt or you've paid the NHS surcharge as part of your visa application, it's 150% of the cost of the care. So it's a way of recouping some more money into the NHS. I'm just gonna, I think that thing that flagged up there was a thank you. I don't think we've actually got any questions. What I'm going to do is ask each of the speakers to just have a final say if they want to. You don't have to if you don't want to, but to cover, if you can, particularly Rachel and Hannah, any worries you have around the charging regime putting women off approaching midwives and GPs for care, and anything else that you just want to say for a couple of minutes. The floor is yours. We'll start with you, Rachel.
Yeah, I think it is a worry that the current regime does discourage women from attending appointments, which I think perhaps come down to them not feeling safe. If particularly like Esther's experience, that they feel ambushed when they're just trying to come and have an antenatal appointment, or just trying to recover in their bed after cesarean section, that they feel ambushed and they don't feel safe. So I think, creating that feeling of safety is reliant on not just midwives, but everybody who works in maternity services. And I think, perhaps through strengthening relationships with overseas management teams, actually, which sounds like an odd thing to say, but I think for clinicians to strengthen that relationship, to be able to say, actually, this is completely inappropriate, this isn't the place for you, I will be a conduit between that woman and yourselves, advocating for the women. But actually, I think it comes down to enabling an environment where women can feel safe, and that will make them feel that they're able to attend for antenatal care, hopefully.
Thank you. And obviously, as I haven't introduced myself as a midwife. Sorry, you want to add something now, Sheila? Yeah.
Yeah. I just want to say, sometimes when we go to talk to midwives, sometimes they talk to us as they give us a favor. I think a midwife need to understand they don't give a patient a favor. We are all women. We trust on the midwife. We go to hospital to be attended, to be, to have a solution of our needs. If we focus a little bit as well in the training and explain as well in the midwife what the rule, because I'm gonna tell about what I'm living now. I can't say the area, but I can't say the name of the area, but the area where I live in now, there are a lot of people I can see they put each other, like, because one person work in this in the same country from this area, and then they push the other to go, and then they start to work as a volunteer, and then they give their job, but they don't have no experience, they don't have no no graduation on the area, they don't have no knowledge about this situation, and then they start to work, and at the end of the day they break somebody life. Is a lot of people are dying, a lot of women are dying, a lot of women become depressed because of lack of communication, because of don't feel supportive. A lot of women are dying because they feel like if I go to hospital, I'm gonna lose everything. I don't know if you had a couple of months, there was a lady who killed herself and they killed the kids as well. in the USA. She faced a problem because the hospital, the nurse in the hospital, they say to her, things not supposed to be. And she writes it down in diary, but she died already. Let it change. I believe we can change. I believe we can support each other. I believe we can say to the woman, oh, look, if you need, I'm here. I'm not going to give, that is not a favor. That is my job to help you.
Thank you, Sheila. I think Rachel referred very early on to the Embrace study, didn't you? And this is, one of the ways in which we know how poor the outcomes are for Black women and minoritized women compared to white women. And I think it's really worrying. And it's one of the things, isn't it, that the government and the inquiry is looking at. But I think lots of us, as I say, I'm not a midwife, but I'm aware of some of the statistics. And actually, when you're living that life, that must be so much of a worry. I think one of the things that maybe one of the midwives can pick up on is the problem with not presenting early in your pregnancy and not seeking help. I think raises the risk of having a very risky pregnancy and poor outcomes. And so those relationships right at the beginning that you've talked about, Sheila, in terms of going to the professionals early on are really key, aren't they? Hannah, I don't know if that's something that you can touch on or if there's anything else that you want to say.
Yeah, no, I completely agree. And I think, we know to a certain extent that NHS charging does discourage women from attending appointments, especially early on in pregnancy. And we know that is associated with poor outcomes, but also so is stress during pregnancy. And everything that you've been speaking about, Gila, just that it lends itself to that very stressful environment. So I think it's a vicious cycle, really. And I think, the ask is not for midwives to be experts in immigration policy because it's complex and it changes week in, week out. That's difficult to know. But I think if we can just let midwives know that by asking women about their immigration status and their wider social needs, we can put more support in place and signpost and just stand beside them, really, in the way that Gina was talking about there, and offering to support, even if you don't have the answers, to do that.
Thank you. Thanks very much for that. Esther, is there anything else that you'd like to add? I know that you've given us lots of advice and food for thought, really. So it's absolutely fine if there's nothing else. But I will give you the final word if you want it before I wrap up.
Yeah, I just want to say that we have to do all this thing together. Nobody's an island of their own. So we need each other to survive it. Thanks.
Yes, thank you very much. And I think that does speak to what Hannah just said. We're not asking, and what Rachel said earlier, we're not asking for people to be expert. We hope that in writing this brief guidance, it'll help people understand that there is a role for the midwife in this and what their role is, as Rachel, Julia, Esther and Hannah have so eloquently said. We don't have any more questions, so I will just wrap up by saying thank you so very much to all of the participants, to people who put in comments and questions, to those of you who will be watching this on the internet once it's recorded and published. And thank you for those who took their time today, and thank you to Rachel from the Royal College of Midwives for helping to write the guidance and for speaking about it today. To Hannah, to Esther and to Sheila, I hope that you felt it was worthwhile being with us. Thank you so very much for your contributions today. And I'll end it there. Goodbye.
Thank you.
Thank you. Thank you for having us.